Today I'm going to talk about trauma, talk a little bit about how PTSD manifests in individuals who have intellectual disabilities, and also talk a little bit about understanding trauma from a developmental perspective, and also in terms of the specifics of the trauma, which can be very enlightening and can give us more ideas about how to intervene in this particularly difficult disorder to treat. So DSM-5 did make some modifications to the diagnostic criteria for PTSD, and part of that was an expansion of the definition of trauma. It still focuses on the threat of death or serious physical injury, but it also includes direct exposure, that the person is the victim, witnessing the event, or indirectly by learning that somebody very close to the individual has experienced the trauma. Also, they included the potential post-traumatic effects to first responders and healthcare professionals who would be responding to the aftermath of a particularly traumatic event, but they specifically excluded that the individual is only exposed through media and so forth. And why is trauma a particularly important issue for folks who have intellectual disabilities? One is simply that statistically they are more likely to have disruptions in negative life events, as Ryan found in her study in 1994. Also, we know that individuals are more vulnerable in the community at large in general for many different reasons. And they can also be traumatized by life events because they have a failure to understand context. So, for example, for the average person, we can probably explain what a blood test is about. If an individual isn't really able to understand that, their experience is simply that a bunch of folks have held them down and attacked them with a needle. So various things that ordinarily we can help people to understand so that they're not traumatizing may simply feel to the individual who has a pretty significant disability like assault. Many of the people we serve also live and work around other people who have behavioral problems that involve aggression. So it's very, very common, I think we know, for the clients that we serve, number one, to have been assaulted by others, to live with people where there is a constant threat of somebody becoming agitated and assaultive, and also to observe other people being restrained or being assaultive to each other. So individuals are living in environments that potentially expose them to a huge amount of aggressive behavior over the course of months or years. Self-protection and resilience does tend to correlate with intellectual functioning. So when we're talking about people who have an intellectual disability, these are individuals who will have difficulty recovering from traumas, so they may be much more likely to manifest post-traumatic symptoms. And realizing that you have a disability can be traumatizing in itself. And a lot of authors have commented about how difficult that is for individuals. What I've tended to see in my practice is usually in late adolescence or early adulthood, many of the individuals that I serve have a lot of crises around younger siblings starting to attain various milestones, various coming of age things, that suddenly they're beginning to think, wow, I'm not going to have a driver's license, and I'm not going to go away to college, and I may not get married, and I may not have a family of my own, and that becomes a very difficult thing for many people. And other things that increase people's vulnerability to trauma. One is simply institutional care. And here in California, we are one of the states that continues to have rather large institutions, often with very large wards or residential units, where unfortunately, because there are so many people, despite the best intentions on the part of care providers, it tends to be rather impersonal. It can be very inconsistent in terms of the milieu at any given time, and people are housed with other folks who may have difficulties with impulse control and again be repeatedly exposed to various aggressions. And in general, folks have relatively less control over their lives, so individuals can't take the steps that the average person would take in order to limit their exposure. That these aren't folks who can say, gee, I really hate this roommate, I'm out of here, and control their milieu so that they are more comfortable and they feel safe. Unfortunately, nonverbal people can often be targeted by perpetrators because they're unable to report. And individuals who are nonverbal are at very, very high risk for being particularly sexually molested. And individuals' difficulties with their intellectual skills, their neurocognitive skills, can also put them at risk. That if you have difficulty with attention, if you have difficulty with sensory integration, if you have difficulty interpreting the interpersonal environment, you're going to be pretty unlikely to be able to maintain your safety, or at least you're going to be very limited in that capacity. And a lot of people put themselves at risk because of a strong desire for social acceptance, and I'm sure all of you have observed that in working with individuals who have intellectual disabilities. How many men and women put themselves in abusive or exploitive relationships because they want to be with somebody who lives in the mainstream. People make incredible sacrifices in order to have that life where they're not stigmatized and not immersed solely with other individuals having intellectual disabilities. And often those relationships can be very, very abusive to individuals. Folks can have difficulty identifying unsafe situations. A lot of times, well, I'll just tell you a story. One of my clients, as an example, was late for work, and to get to work, he had to leave the bus stop and go around the corner to get to this place where he was working, and he was late, and he figured that if he crossed behind the strip mall, that he would get there quicker, which was absolutely correct. However, it was 5 o'clock in the morning, it was dark, and there were some guys back there who beat him up and took his money. And I think most individuals would kind of identify that as being a somewhat risky situation, that you wouldn't really want to go behind the strip mall when it's dark outside, but he really wasn't able to process that and therefore put himself at risk. Individuals also can have difficulty securing help. They may not know who to go to, how to express themselves, what to say, when to say it. So that they, become mired in a situation where they're at risk. Or sometimes people won't bring risky situations to folks' attention because they're afraid of being blamed. That I think that many individuals have had the very unfortunate experience that when something goes wrong, people kind of assume that they may have had something to do with it. And some folks will have even come to be adaptable in terms of volunteering when something goes wrong, that it's like, oh, I'm so sorry, I'm sorry, even when they may or may not have had anything to do with the situation. When they get into a situation where they have been hurt, where something seriously has gone wrong, they may not feel comfortable coming forward and telling us about it. And folks may have difficulty setting limits with other people, and many of the individuals we work with have comorbid physical disabilities, so defending themselves, fending somebody off, running away may not be a very feasible option for them, again, putting them at more risk. And unfortunately, individuals may not be believed when an assault occurs. And part of that is made more complicated by the fact that some of the individuals that we work with do fabricate stories or do communicate things in very idiosyncratic ways, or have had a past track record of making false allegations. And despite all of that, these individuals are at equal risk for being victimized in their lives as well. Figuring out the prevalence of PTSD in the ID population is pretty difficult. There's not a lot of research on that. In the general population, about 5 to 10% of individuals have some post-traumatic manifestations. Ryan looked at 310 consumers and determined that 16% met criteria in the DSM-4 for PTSD, and all of them had very, very serious histories of abuse. And when we think about post-traumatic manifestations, it's important to think about what the trauma was like, because the things that the person is dealing with are going to, terms of their post-traumatic manifestations, are going to mirror a lot of the aspects of the original trauma. The age and circumstance of the victim can have a marked impact on what PTSD looks like. In general, if an individual has been traumatized in early childhood, you see a tremendous disruption in the person's ability to understand social interactions and boundaries, that the trauma early in life interferes with that person learning basic skills about boundaries, reciprocity in relationships, and what is reasonable to expect from others in their milieu. And it really is carried forward as a very prominent deficit for these individuals that they really struggle with. And you can imagine that, particularly if you're working with somebody who has autism spectrum concerns, already that individual is having difficulties interpreting social signals, and now you're compounding that with a lack of these skills. And it's very different than when you have an individual who has acquired that knowledge and those skills and then is traumatized later in life. And that's kind of intuitively obvious, but it can also occur in much more subtle ways. And the best example of that that I have comes from combat veterans, that when combat veterans were coming back from Vietnam, people were saying, why are these men having so much trouble reintegrating? That they looked very different from their predecessors coming back from Korea and World War II, and had a whole host of different kinds of problems. And people really had difficulty understanding that. Well, one of the key differences had to do with exactly this, the age and circumstance of the person who is exposed. That the average soldier who went into combat in World War II was 26 years old, usually had established a life partner, a career, and more often than not was a volunteer rather than being conscripted. Whereas the average soldier who was going into combat in Vietnam was 19. These were kids. Most had been drafted. Most had not established their adult roles. They did not have their career intact. They did not have their families intact. They didn't have a life partner. They were adolescents, essentially, and then were exposed to the same kinds of stressors, but came out of that experience looking very, very much different in terms of the kinds of symptoms that they had and their coping strategies to deal with those symptoms. We also need to think about trauma in terms of whether it's a single incident or whether it's repetitious and prolonged. So, for example, a severe motor vehicle accident or some sort of accidental occurrence might be a good example of a single incident. And repetitious and prolonged kinds of traumas, living in a household where there's domestic violence, being the victim of childhood sexual abuse. But we also need to think about, a lot of times we think about various events as being a single trauma. So, for example, a natural disaster, or if you talk to combat veterans, they'll talk about a few episodes that were particularly traumatic for them. But we also need to keep in mind that there's a lot of sequelae from those particular incidents that make those experiences repetitious and prolonged and not a single episode. Loss of control and helplessness are absolutely core issues in PTSD and trauma. That if trauma teaches us anything, it's that we can be walking around in our healthy state of denial and someone or something can come in, shatter your life, and leave you to pick up the pieces. So individuals have this tremendous sense of betrayal about being safe and having the thought that they can be safe. And any subsequent experiences that give that person a sense of loss of control, or a sense that somebody else is in charge, or a sense that they are helpless in a circumstance, will really exacerbate all of their symptoms of PTSD. That those are the kinds of circumstances when you're interacting with people or when you're treating people, that if the person feels that they have no control or they're not an active participant in that process, you will see people dissociating, panicking, becoming aggressive, having extreme distress. And one way that we can really help people mitigate their symptoms is give them a larger role in controlling their services and participating in the kinds of interventions that we utilize. We talked a little bit about the disruption of reciprocity in interactions when individuals are traumatized early in life. This also occurs with respect to neglect, and one of the recent concerns has been that neglect is far more underreported, but also far more prevalent than actual abuse. And yet has very similar kinds of impact. That essentially what we're talking about here is that so-called serve and return between the caregiver and the child, that under normal circumstances, the child should be learning that if they're pleasant and happy and cooperative, they are treated in a pleasant, happy, and cooperative manner, that there are reasonable boundaries to what they can and can't do, and that the response of the care provider is reasonable and in proportion to the behavior of the child, but also respects those same boundaries. So pretty complex things to be learning at a very, very early age for kids. And if they don't get that, what happens is that they may be acting in a certain way, but they're not getting the reciprocal response. And that child goes forward feeling that the social milieu is incredibly dangerous and unpredictable, and something that is completely unmanageable and incomprehensible. So these are individuals who are really missing some essential tools for managing the world, and are going to feel extremely uncomfortable whenever they are in situations where they have to interact with others. I see people nodding. You've had this experience working with folks. Unpredictability is often a core issue in trauma, as well as arbitrary and inconsistent rules. So if individuals are in a situation where there's abuse and neglect, what they will often talk about is that they never know when something is going to be okay. That folks will relate things like, I got up on Monday and I took out the garbage and I did my chores and I got ready for work and everything was very fine, and my care provider was okay with me and sent me off to work very peaceably, and then I did the same thing on Tuesday and now I'm here in the ER because I was beaten. I don't understand. So that, that incomprehensibility, just never knowing what is going to come next. The more invasive trauma is, the more likely it is to produce post-traumatic effects, and the more severe those post-traumatic symptoms are likely to be. And isolation is often a core issue in trauma. That it's very common for individuals who are being abused and being exploited for the perpetrator to isolate them from others who might give them feedback about what's going on. So it's not uncommon for a perpetrator to say, not permit the individual to have contact with friends or family unless the perpetrator's present, or to not have contact with them at all, or where there's a family where there's a lot of abuse, that family frequently will live in a remote location or deprive the victim of transportation, all the way to the extremes of locking people in closets or in rooms when the perpetrator isn't present. And that has one very, very significant impact on clinical evaluation, and that is that individuals who are the victims of abuse very often don't realize they've been the victims of abuse. So that if you're taking a history and you're just asking somebody, were you abused, when you were a kid? Did you have abusive experiences? Will often say no, when in fact they have had very significant experiences. And the best example that I have of that is a guy that I worked with whose trauma history was that when he was growing up, his father was extremely violent, would whip him with switches, would whip him with cords, the buckle end of the belt, and so forth. So he had a lot of scarring on his back. And he went through school and so forth, and he gets up into junior high and high school where kids go to gym, and then they head for the showers and they change and so forth. And one day his friend said, "What happened to you? What's with that?" And he said, "I looked around for the first time and realized that other people didn't have these scars. And for the first time, it dawned on me that not everybody goes home to a beating." So here was a kid who was kind of thinking that this is normal. You come home from school and somebody beats you up, and had no concept that this was out of the norm for how one should treat one's kids. Constant terror is often a part of trauma, particularly these enduring kinds of traumas. And people will say they feel like they're walking on eggshells. They never know when something is going to happen. They feel like a lethal threat is around every corner, every minute of the day. And blaming the victim is a really important part of the dynamic of trauma and is something that I think all of us need to be aware of. It occurs in two different ways. It occurs on an individual basis and it occurs societally. On an individual basis, it is a normal defense against the terror that we feel when we hear about trauma. So if I'm sitting and in my normal healthy state of denial and talking with somebody who's starting to tell me about this horrific experience that they've had, I'm going to start to get anxious and I'm going to start to get horrified and my denial is going to start to be eroded. And I'm going to start thinking, if it can happen to her, it can happen to me. And then we recruit these normal defense mechanisms about why I'm really safer than she was. And those usually take the form of various rationalizations about, well, she made worse choices, or I have more resources, or I have better judgment, or I have whatever. But ultimately, it's kind of building a case about why she messed up, and that's why this happened, and why it's not going to happen to me. We all do this, we all feel it, just recognize it and observe it and counteract it in your interactions with other people, and don't beat yourself up about it. We all do it, we can't help it. It's part of the norm. When that occurs in a societal basis, we've all seen it, that when the World War I veterans came back with shell shock, just horrific PTSD from trench warfare, they were told the reason for that was because they were not patriotic enough and did not have the moral fiber to defend their country adequately. When the Vietnam veterans came back, they were told that they were just a bunch of drug-addled baby killers, and that's why they were having trouble reintegrating. And I think some people here are probably old enough to remember a time when if a woman was sexually assaulted, it was because she was asking for it, and she really wanted it to happen. So, you know, we've seen these sort of societal things, and again, we need to just be aware that when we hear about trauma, it is traumatizing, and we are going to mount these defenses against it, and you know, one of the things we need to keep in mind is that the individuals we're working with are not oblivious to this, that they feel not only if it's coming from us as individual service providers, but also they're immersed in a society where they are going to hear these things and feel these things and experience these things, and helping people to cope with that is a part of what is helpful for folks who have PTSD. And lastly, periods of remorse or special treatment from the perpetrator are very, very common, particularly if you look at situations where children are chronically abused, that the perpetrator will be highly abusive of the child and then come back with gifts or special privileges or a special trip to kind of draw the child back in, and then be very abusive again and then get some special rewards and so forth. And you can imagine, again, what that does to the child who is trying to learn about appropriate interpersonal relationships and interpersonal boundaries, that instead of learning kind of what is the middle road and the norm of how people should interact, they're bouncing back and forth on this teeter-totter of extremes that is extremely confusing and extremely chaotic and very destructive to their sense of their interpersonal power. And the DSM-5 criteria for PTSD broke down the symptoms a little bit different than DSM-4. You have the traumatic event. Then you have intrusion, which is the re-experiencing of the trauma in various ways. You have avoidant symptoms, where the individual does all kinds of things in order to try not to re-experience the trauma. You have changes in cognition and mood that are persistent and often are distorted and kind of get in the person's way. And lastly, you have permanent alterations in the person's physiologic arousal, in that crisis fight or flight response. It has to be over a month. It has to cause significant distress or impairment. And it needs not to be due to medications or substances or illness. And I won't belabor that. But let's talk about the symptom clusters. The first is intrusion, and this is just all of the different ways that the person who has PTSD re-experiences the trauma in their daily life. And the most common is intrusive memories. And the one thing that we need to kind of keep in mind about traumatic memories is that they're very different from the quality of average memories, that any one of us can kind of think about our last vacation or what we were doing yesterday, and we can voluntarily reach into the past, retrieve that memory, work through it, and then put it away when we're done with it, and manage a lot of the affect that might be going on. It's a pretty mundane experience. Traumatic memories are not like that. They come unbidden. They intrude into other activities and interfere with concentration and performing other activities. They are laden with the full affect of the trauma, so they are extremely distressing for the individual, and they're very hard to put out of mind, and tend to linger and interfere and recur again and again and again. Children and individuals who have intellectual disabilities can express this and other re-experiencing symptoms through repetitive play and very obsessional repetitive play, and can appear just very disorganized rather than specifically upset about a particular issue. And they may not be able to tell us, I'm having this memory and therefore I'm very upset. So you may just see the arousal and the disorganization and these repetitive behaviors. Traumatic nightmares are also very common. And often what people will have is either a nightmare of the specifics of the trauma, or they may have dreams that are simply frightening or symbolic of the trauma. And for the individual who has an intellectual disability, again, they may not be able to tell us what that dream was about. They may not relate that dream to the traumatic experience, but sometimes what families will report or what the person will exhibit is that they are up in the middle of the night in a panic. Sometimes waking up care providers, sometimes refusing to go back into their room. Sometimes individuals will refuse to go back into the bed, and it's very common for individuals who have PTSD to want to sleep under the bed or in a closet or in some defensible space rather than sleeping on top of the bed. And usually you can see the level of arousal, the level of fear that the person has. Flashbacks also do occur, and I think we're all familiar with kind of the portrayal of very severe flashbacks where the combat veteran goes into a situation, thinks they're back in the situation, and actually enacts the trauma. I'm sure that folks have heard, about news stories where an individual went into the 7-Eleven and gathered up the patrons there, trying to protect them, and was hallucinating that they were back on the battlefield and that the enemy was approaching, and those sorts of things. Those kinds of dissociative episodes do in fact occur. They can occur. Fortunately, they're relatively rare. And what we usually see in flashbacks is a more partial kind of dissociation where the individual is having this really intense dreamlike experience, but they sort of have one foot in reality. They kind of know that that's not exactly happening. And what you see from the outside instead is an individual who has this glazed expression looking off into the distance. The veterans call it the 1,000-yard stare, oblivious to what's going on around them, not readily arousable, and just kind of immersed in this experience for sometimes very lengthy periods of time. And then the last two really relate to triggering. And triggers are just things that the individual associates with the trauma. And they can be very transparent, very obvious. So, for example, the combat veteran who says, I hate the 4th of July because those fireworks are too much like shelling. Or I can't deal with the smell of diesel fuel. But it can be more subtle than that, and it can make it very hard to identify triggers sometimes, particularly when we're talking about domestic violence or abuse of a child. So it could be something like the smell of alcohol, the smell of a particular cologne. It could be something as subtle as the color or the slant of sunlight coming in through the window at approximately the hour that the perpetrator would come home from work. So sometimes very surprising things can be triggers, and you may kind of stumble across them in the course of working with somebody. And one of the things that's so important about this is that you do want to minimize triggers when you can. So if you can identify them, it's very, very important for folks. And that's why those ABC charts are so incredibly important. And one of the things that's really you have to do with direct care staff is really work with folks about how to accurately report when the individual is dissociating, or when the individual is having an outburst, or when the individual is extremely agitated. Who was there? What did they look like? What was going on? What time of day was it? What was the environment like? With a lot of specifics, because that's what's going to allow you to identify what is triggering the individual. And avoidance is simply all of the intentional things that the person does to try to avoid the thoughts and the feelings and the triggers. And people can become quite constricted in their activities as a result of avoidance, even kind of locking themselves up in their rooms for extended period of time, avoiding activities that they've previously found very enjoyable, and so forth. In terms of the negative alterations in cognition and mood, one of the things that can happen is individuals may not have recall of many of the aspects of the assault, or may even not remember the traumatic event. And you can imagine how difficult that becomes when you suspect that abuse is ongoing, and you're suspecting that something's occurring if the individual is unable to report because they can't remember. It's really important to make sure that we don't communicate to people that we think that they're concealing something, and make sure that, that we communicate that we understand that the person simply may not remember what's going on. Individuals may also have persistent negative beliefs about themselves or the world. For individuals who have relatively little expressive language, they may verbalize this in very rudimentary sorts of ways. So, for example, one of the women that I worked with who had had a series of serious physical assaults would sit in the corner and just say, "bad girl," over and over again. Others may blame people or others unrealistically for the traumatic event, and that can be quite unrealistic at times. And individuals often have a lot of feelings related to the trauma, and often it involves blaming oneself, and the veterans call it the woulda, coulda, shoulda effect. That very often individuals will rework the trauma in their mind and think, I should have been able to prevent this. If only something were different, I would have been able to prevent this. And will just beat themselves up about how they should have dealt with things differently, when in fact what we need to reassure people is this was not your fault. This could not have been prevented. It's terribly tragic that it occurred, but it is not something you should have prevented. And also we see folks who are diminished in terms of their involvement with others. They feel very alienated. They can have constricted affect. And the best example that I have is, did folks see The Hurt Locker, the movie? Remember the part where the premise of the movie is it's looking at this guy's life who goes to the Middle East, and his job is that he is finding and detonating various explosive devices, and he sees all of these horrific things. And he comes back to the US, and there's this one scene where he's shopping with his family in the grocery. And you can just see his utter disgust and alienation about, here's his family kind of reaching for things on the shelves and engaging with each other and so forth. And he's just like, this is irrelevant. What is this? Just a sense that it's very, very kind of unreal. And one of my clients, I think, expressed it best when she said, every day my re-experiencing of my trauma is so much more real than my everyday life. So people are really riveted in that traumatic experience. And then the physiologic hyperarousal. One thing that we do know about folks who have PTSD is that they do undergo permanent changes in terms of the stress response axis. There are changes in terms of how they produce cortisol, when it peaks, when it doesn't peak, how they metabolize epinephrine, and basically, these are individuals who are primed for the fight or flight response, that it does not take very much for them to get into the traumatic experience, to be in crisis mode, very aroused, very upset, very agitated, and then it takes them a very long time to calm down because they are just different. That observation has actually given rise to some interesting speculations about what PTSD is, and whether it's really a disorder or whether it's a adaptive function for maladaptive stress. That people have pointed out that when we were on the savannah, we were not the toughest critter in the forest, and that probably our survival depended upon having been confronted with traumatic experiences and learning not to sleep very much, to be incredibly hypervigilant, to fight hard, to fight mean, to run away fast, and to be constantly on guard. So it's quite possible that we've inherited this from our forebears, and that what was once adaptive in very different life circumstances now looks like a disorder among people who are living in much safer environments. The kinds of things that you see, irritability and aggression are a huge problem for the person who has PTSD. These are individuals who can become enraged very quickly. They are enraged out of proportion to what is going on in their life circumstances. They stay angry for a very long time. It takes a lot of effort on their part to calm down. Sometimes individuals can dissociate during the course of these rages and don't recall what they did, or sometimes don't recall what got them angry. And all these behaviors, by and large, are quite ego-dystonic. People feel badly about it. So you can imagine how problematic it is for folks that they have these rages and afterwards feel miserable about it. And individuals may approach care providers and apologize effusively, or may feel terrible about themselves. It may feed into those negative cognitions about guilt and inadequacy and being to blame for things. Self-destructive and reckless behavior can take many forms. Sometimes it's simply inattention to the person's safety. The individual who usually would pay attention to crossing the street or who would get out of the way of an aggressive peer who now just sits next to that person while they're raging and swinging, or walks across the road without paying any attention to the traffic, and kind of just neglects their safety. That is a very typical giveaway that an individual has had traumatic experience. If you see the person who always sits next to the guy who's very aggressive, who tries to pacify that person, who tries to mollify that person, very often that's an individual who has post-traumatic manifestations and isn't protecting themselves. Hypervigilance you can observe, where the person is constantly looking around in the environment for where the next threat might come from. And exaggerated startle response is one of the sort of core symptoms that we associate with combat veterans and PTSD, where the traditional thing where a car backfires or the person hears some sort of loud noise and they assume a defensive posture. Along with the exaggerated startle response, individuals who have PTSD don't experience extinction of startle response. That for the average person, you hear a loud noise, you startle. It happens again, you might startle again. After 3 or 4 times, it's simply an annoyance, and it extinguishes. That doesn't happen for the person with PTSD, where that exaggerated startle persists for a very, very long period of time, and they get no relief from it. Problems in concentration are very, very common and also very incapacitating for people. You can imagine if you are constantly fearful, agitated, walking on eggshells, and looking around you to find where the next threat is coming from, how are you going to concentrate on anything else? However, very few people are going to tell you, I have this problem with my concentration. And instead, what people will observe and what people will report is they can't remember things. Because if you can't concentrate, you can't form a memory. And that can be very, very incapacitating. One of the veterans that I worked with at one point at the VA was a guy who dealt with things with humor in a really wonderful way. And he had this sort of spiel that he had about his problems with memory, and he would say, my wife tells me to get 2 things at the grocery, and I get to the grocery and I've forgotten what they are, so I went back home. So she gave me a list, and I went to the grocery and I forgot that I had a list, so I had to go back home. So, and on, like hole in the bucket, right? And, but I think it illustrated, very well how incredibly incapacitating this can be. We want people to reintegrate. We want to help people with post-traumatic concerns. We want to get people back to their jobs, but they may be dealing with a symptom that really makes that extremely, extremely hard for them, and we may need to provide a lot of supports for individuals in that regard. And sleep disturbance is also, very, very characteristic of PTSD. Sometimes people simply have insomnia and they are not able to sleep, or only very, very fitfully. But the more typical presentation is that the individual falls asleep, but then reawakens multiple times during the night, sometimes in response to traumatic nightmares, sometimes simply in a panic, in a state of arousal, and unable often to go back to bed. So in making the diagnosis of PTSD in folks who have intellectual disabilities, there's clear consensus that post-traumatic manifestations do occur in people who have intellectual disabilities, and that the diagnosis is very appropriate for many people. But we need to be aware of some of the pitfalls and some of the difficulties in making the diagnosis in this population. And one is simply that people have a very large range of ability to communicate, and communicate in very different ways. So that a lot of the kinds of criteria that require self-reflection and self-reporting are going to be impossible for many of the individuals that we're serving. And we need to take that into consideration. We need to take into consideration that the communication may be more through repetitive behaviors, through reenactment behaviors, and so forth, rather than by what the individual tells us, that we need to be very keen observers. And again, those ABC charts are really important, and helping to make sure that direct care staff are knowledgeable and able to make those observations and report them accurately. Diagnostic overshadowing is common, and that simply refers to that the symptoms of the PTSD are misinterpreted as being due to the intellectual disability itself. So an individual who has difficulties with impulse control, who may be likely to have exaggerated hyperarousal, who may have dysregulation of affect and behavior, could have that as a part of their intellectual disability, and yet those are core symptoms that go along with PTSD. And it's very important to try to get that history about what changed and when, and what was going on prior to the change in their behavior. And lastly, the symptoms may simply be very different for people. And DMID attempted to address just that issue. And are most people familiar with DMID? The Diagnostic Manual for Intellectual Disabilities. NAD put it out in 2007, and now they're revising it to be based on DSM-5. But they recommended a number of modifications to the diagnostic criteria in order to accommodate for the individual's intellectual and developmental level. When they looked at the criteria for intrusion, for re-experiencing, they noted that individuals may have intrusive recall and flashbacks, but what you may in fact see is exactly that reenactment. You may see repetitive behaviors, you may see symbolic play, and you may see aggression or self-injurious behaviors that may have some pertinence to what exactly happened in the trauma. Sometimes you'll see sexual acting out of various sorts, sexual behaviors, repetitive things, or sometimes sexual aggression towards others if the individual has a history of sexual trauma. The content of the nightmares may not be apparent, as I was saying earlier. And again, the person may simply awaken at night in a very aroused state, may seek help or comfort from other people, and may be extremely unlikely and unwilling to get back to their bedroom. And they may associate those nightmares with that place. And individuals may not be able to engage in the kind of abstraction and self-reflection that's necessary to link the trauma with their current distress. So again, we have to make our best inferences about that. And I think we need to keep in mind that a lot of times people will come and present in the office and say the outburst occurs for no reason. Because they don't really understand the underpinnings. And sometimes a very careful history can give you clues about that. Ryan gave a really wonderful case report of a woman who was having outbursts of extreme distress and agitation, and would tear things apart and turn things over and so forth for no reason. And she did a very, very careful history and found out that the trigger was, in fact, when people would run water in the bathroom. And the reason was that her mother had had a disability of her own and would run scalding water in the bath and then place her in the bathtub. So every time, not really recognizing what she was doing, and that all she had to hear was the water running, and it would trigger that anticipation of that pain. Modifying the criteria for avoidance. Again, individuals may not be able to verbalize that, may not be able to explain that, and what we may see instead is simply the person who kind of locks themselves away, who is no longer doing the things that they used to do, who isn't going with the flow in a congregate setting, and so forth. And it's really important that staff understand that it's not noncompliance, that people are not simply being oppositional. And again, the specifics are very important. A careful analysis can reveal aspects of the trauma and can help us to understand what it is that the person is avoiding. And in terms of the criteria for the negative alterations in cognition and mood, again, the things that people verbalize may be very simple but very direct. And often we can infer from behavior. If the person is engaging in self-injurious behaviors, that may indicate that the person is having guilt and self-recrimination. If they are tearful, that sense of remorse and loss and so forth. And again, we need to make sure folks are not seeing that as noncompliance. In particular, that when individuals are behaving in these ways, it's very important for staff not to be trying to engage the person to force them to do it, or to apply behavioral interventions that penalize the individual for non-participation. And the pitfall for alterations in arousal and reactivity, again, we can readily observe a lot of the aspects of hyperarousal, that the person looks agitated and sweaty and hypermotoric and hypervigilant and so on and so forth. But we need to make sure that we're not confusing that with aspects of the individual's neurodevelopmental disability. That we work with a lot of individuals who have times when they are agitated, when they are dysregulated and so forth. And again, I think it's helpful to think in terms of, has there been a change longitudinally that we might be able to attribute to the traumatic event? And then what do you do about it? PTSD, don't laugh. PTSD is a very, very difficult condition to treat because we don't have any magic bullet for it. But there are a lot of things that we can do and that we must do. And the first thing is that we need to ensure that the person is in a safe environment. Because PTSD is not going to get any better if the individual is consistently and repetitively exposed to threats of violence, to things that are triggering, to injury, and so forth. And sometimes that's hard to do when an individual is living in a large congregate setting and may not have a lot of options. But it's certainly something to think about. And even in those settings, I think it's really important to make sure that individuals are taking into, care providers are taking into consideration options that they may have to break down a large environment into smaller environments, to cluster people together differently, to perhaps structure schedules differently so that that people are less likely to be exposed to individuals that they clash with, or individuals that may be threatening to them, or individuals that they may have experienced assault or aggression with. Thorough medical assessment is really a must. To make sure that the individual is not manifesting these things due to a variety of medical conditions that can range from complex partial seizures to thyroid disorders and so forth. And if you can identify triggers, certainly look for those triggers and try to understand the triggers in terms of your knowledge of the trauma. And if you can get more information about the trauma by reaching out and collecting information from previous care providers, from family members, from anybody who might have more information about what that individual's experiences may have been, that can be extremely enlightening when you're taking a look at what is causing that person to have the agitation and to have these various symptoms. If you can get that history, if you can identify the triggers and remove them, that's fabulous. But I think we often encounter situations where you can't get rid of the trigger, where the trigger is something that is integrally a part of the environment, and we have to help people to deal with the trigger. And one of the things that is very helpful in that regard is sensory modulation techniques. And are folks familiar with that? That it's basically looking at all kinds of environmental stimuli that will tend to activate anticholinergic responses, which tend to be calming to individuals. So probably folks have seen, quiet rooms and calming rooms where they tend to be dimly lit, they tend to have very neutral colors, they have comfortable seating, sometimes they'll have music that is sort of soothing for the person. I know we don't like to use edibles to help people calm down, but chewing and sucking on things is very calming for individuals and really engages the parasympathetic nervous system quite a bit. Aromatherapies do work for individuals, and what a lot of people have recommended is providing people with the so-called sensory diet, which is a combination of various sensory stimuli for the individual to use at the onset of post-traumatic agitation, so that they have a number of different techniques that they can be presented with by others, or that others can engage them with, or that they can utilize for themselves in order to get that calming response. One thing that I would say about sensory diets, though, is that very often people will initiate these plans, and then 6 weeks down the road or eight weeks down the road, like they're not working the way they originally had. Don't be fearful. That's pretty typical of sensory diets. And a certain amount of novelty has to be introduced over time in order to keep these regimens effective. And it's always at that point, as soon as it seems like it's not working as well, it's time to change up what the person is exposed to and what kinds of activities are offered. It's always helpful to revisit the aromatherapy and so forth, probably change up the place and those sorts of things. If the person has been doing a lot of things that are very quiet and inactive, they may respond to things that are a bit more active. They may respond to things that are more proprioceptive, like rocking or spinning or being on a swing. One of the guys that I worked with in Las Vegas was a big fan of Michael Jackson, and one of the things that really helped him for a while was to put on the Michael Jackson tape and get out his glove and his hat and let him moonwalk around for a while. And it was very distracting and really would tend to disrupt that post-traumatic cycle that he had. And it requires a lot of creativity to keep that sensory diet fresh. Giving people as much control as possible is really critical. Again, the core issue in trauma is that somebody has taken away your control and hurt you in a way that you thought you should have been able to prevent, but you couldn't. So it's really an assault on the individual's sense of autonomy and self-determination. So everything that we can do to help people participate actively in their interventions and in the design of their treatment and their plan will help you to manage those post-traumatic effects. And that can be things that are as complicated as sitting down and having, very elaborate conversations for treatment planning and planning the sensory diet and those sorts of things. It can be as simple as how we communicate with people. That one way to give people a sense of control is to involve them as a partner when we talk to them about changing their behaviors or managing their feelings at a given time. So very often I think people, providers sort of panic and get in there and they're very directive. Stop that, don't do that, why don't you go to your room? Not necessarily in a hostile way, but in a firm, directive sort of way. Those sorts of interventions are likely to inflame the person with PTSD because they feel that now they're on the bottom and guess what? Somebody's on the top. So it makes that person feel very vulnerable. So it's important when we communicate with individuals, especially if they're beginning to get a little bit aroused, a little bit agitated, as to communicate with them as a partner. Well, it looks like you're getting a little bit, anxious there and like you're getting uncomfortable. Would you say that's true? How are you feeling right now? What do you think we should do about this? What do you think would help you right now? Would you like to sit down and have a glass of lemonade and talk with me about that? And helping the person to disengage from the trauma and engage with you in planning, what do I do next and how do I deal with that? Consistency and clarity is very, very important. And again, when we're talking about how trauma impacts the social milieu and how that's perceived and experienced by the individual with PTSD, if that individual is in an interpersonal milieu where there's not consistency, it begins to replicate or at least trigger the circumstances of the trauma. So things need to be very, very predictable and very reliable for that individual. And that takes a lot of training for direct care staff in terms of modes of communication, how and when they do things. Even sometimes the order in which things are done can be important to the person who has PTSD. Psychotherapies are very helpful. And in particular, there's a really good literature about dialectical behavior therapy modified for individuals who have intellectual disabilities. It's very, very helpful. A lot of times people do need a lot of support, however, to engage in that program. And individuals will have individual sessions and also group sessions, and they always have homework. And they very frequently need help with that homework in order to be able to really benefit from the program, but it is helpful. CBT also has a body of literature to support it. Eye movement desensitization and reprogramming also has been helpful even in individuals who have moderate to severe levels of intellectual disability, mainly on an anecdotal basis, and sometimes the how the EMDR is used needs to be modified, that the individual may have difficulty doing the tracking of the eye unless they have a ball that they move from hand to hand, unless they have other stimulus in the environment that they're able to track and so forth. And relaxation techniques are often helpful and can be combined with the sensory diet. It's also helpful to articulate the serve and return relationship over and over and over again for the individual who has had early trauma. And that is important even in very simple kinds of ways. Again, what you're trying to do is help the person to learn to make the interpersonal milieu more predictable, safer, and to help them to learn that by behaving in certain ways, they have some control over the interpersonal milieu. So when people are interacting with individuals, it's important to give them feedback like, I can see that you're really, really angry and you're yelling at me, and right now that's just making me scared and I can't help you when I'm scared. Can you say that a different way? Can you help me to help you? Again, partnering, but explaining what's going on in that interaction. And the good things too. You know, wow, when you helped me with that and you were positive about that, I was really proud of you. It made me feel really good. And helping people, again, to articulate those interpersonal interactions. And lastly, for a good reason, we have psychotropics, because there is not a psychotropic treatment for PTSD. And I swear if we had it, we'd put it in the water. But But mainly we're using the psychotropics to treat comorbidities. Many people who have PTSD will have comorbid anxiety problems, panics, depression, and so forth, and we would utilize the psychotropics in line with our standard guidelines. Some individuals will present with intermittent or concomitant psychotic symptoms, which of course you would want to treat with antipsychotic medications. But mainly we're using them empirically, trying to help people with sleep and so forth.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.